My name is Jason Brody. I'm a physician assistant. I've been working in outpatient psychiatry for the past 3 to 4 years. Prior to that, I was working in the emergency department, and I have an added qualification in specifically psychiatry, which is unique to our profession as PAs. The presentation is going to be divided into two parts. The first part will cover CARF requirements very briefly, then prescriber roles and training, and principles of psychopharmacology. The second part is going to talk about specific medications and classes. So CARF defines medication use as the practice of controlling, administering, or prescribing medications, and the purpose is to maximize the functioning of persons while reducing their symptoms. We, of course, at Mindful Healing Works do not do medication control, which consists of controlling, storing, or transporting medications, nor do we do administration, which consists of preparing and giving administrations. Even handing out sample medications is not considered administration. One thing to note is that Narcan or naloxone is handled as a first aid supply and is not considered a medication. Narcan and naloxone should be secured, readily accessible when needed, and at least some people are going to be trained on its use and administration. Very quickly, the people who prescribe medications in psychiatry are psychiatrists, physician assistants, and nurse practitioners. They can be referred to by the titles providers, prescribers. PAs and NPs can be called advanced practice providers, or an older term that some people don't like is mid-level practitioners or mid-level providers. Very briefly, psychiatrists are physicians. They do 4 years of medical school, and that culminates in either a doctorate in medicine or a doctorate in osteopathy. They then do residency training in psychiatry. Some choose to do a fellowship for further training in subspecialties. You can refer to psychiatrists as doctors or physicians. PAs and nurse practitioners are very similar in terms of the training and profession. Both are 2 years master's level programs. One of the differences is that PAs are trained as generalists in the same way that physicians are, whereas nurse practitioners do actually pick their specialty while they are in NP school. Both PAs and nurse practitioners are not required to attend residencies, though there are many programs popping up around the country to give them further training after they complete their programs. One big difference is that PAs are legally dependent practitioners, meaning they work under the supervision of a physician, whereas nurse practitioners can practice independently and generally have an easier time opening up their own practice. Generally, it's only appropriate to call physicians doctor or psychiatrist. Other providers who can prescribe psychiatric medications include those who work in primary care, the emergency department, urgent care, inpatient units, and in some states, even psychologists are given the authority to prescribe certain medications. Psychotropic drugs are medications used to treat psychiatric illnesses. They can be classified according to clinical applications, such as antidepressants or antipsychotics, or they could be classified by their molecular structure. Some drugs do have multiple indications, such as the antipsychotics, which could be used for a bipolar disorder as well as psychotic symptoms. Seroquel is a good example. You can give it in small dosages for sleep, mid-range dosages for bipolar disorder, and higher dosages for psychotic symptoms or schizophrenia. Many drugs can also be used in addition to psychiatry for medical and neurological conditions. Propranolol is a good example. It could be used for anxiety, blood pressure, as well as tremors. Finally, the terminology for drugs does change over time. We no longer use the word tranquilizers, which used to refer to meds for schizophrenia as well as depression. If you've ever watched The Queen's Gambit, the tranquilizers that they were using to give to the young girls were likely benzodiazepines, which today we use for anxiety and panic attacks. Because both genetic and environmental factors influence a patient's response to medication, we generally recognize that no drug is going to be universally effective, and there's also no evidence that any one particular drug is superior to another for any given psychiatric diagnosis. As a result, when prescribers make decisions about medications, we usually incorporate information about family history, such as an immediate family member who might have responded well to a specific medication. We also consider patient past trials and responses to specific medications. We also ask about patient-specific attitudes about certain side effects. Some patients may want to avoid medications that have a risk of weight gain. For me as a provider, I may want to avoid a medication that will mess with a person's glucose levels if they are pre-diabetic or diabetic. So pharmacodynamics is the time and intensity of a drug's actions and includes the mechanism of action, meaning how the drugs produce their effects. I'll be talking about mechanism of action for specific classes of medications. Side effects, of course, are one of the most important factors to keep in mind with any medication. It should be known that there is no document that contains a complete list of all the treatment emergent side effects for any given medication. We do have to listen to our patients to see if there are any new or unfamiliar symptoms that come about after we start a medication, and then we have to decide, is this symptom related to the drug, or was it related to circumstances or something else going on? So if someone gets a headache when I put them on a new medication, I have to decide, could the headache have been caused by something else that was going on, stress in their life, dehydration, do they have a history of migraines, or is it legitimately a direct cause of the new medication? Some side effects are time limited, meaning to say that we expect them to occur in the beginning of treatment and then resolve after maybe a week or two. Others present later in treatment and can last for a longer period of time. Life-threatening side effects with psychotropic drugs is generally low. So one of my previous supervising physicians used to joke, he said that it's actually very hard to kill someone in psychiatry. And this is also the reason that we tend to get sued very little compared to other medical specialties. So when we prescribe medications, the most important question that we're always asking ourselves is whether the potential benefits outweigh the risks. Patients themselves will also have varying levels of risk tolerance and will more readily be open to certain medications than others. Suicidal ideation is obviously one of the most well-known potential side effects, specifically of the antidepressants, especially in children and adolescents up to age 24. And that resulted in the FDA putting a black box warning on antidepressants back in October 2004. Now, it should be said that there have been other studies that have been conducted since that time, and they've basically challenged that decision. So common side effects include somnolence, which is defined as daytime sleepiness, and that can affect things like operating machinery or a vehicle. GI disturbances can include constipation, dry mouth, as well as stomach pain, nausea, flatulence, and diarrhea. Movement disorders I'm going to talk about briefly in another slide. Sexual dysfunction can include decreased libido in females and males. For males, difficulty obtaining an erection or maintaining one, delayed ejaculation, or in females, inhibition of orgasm. Weight gain can be caused by fluid retention, increased appetite, altered metabolism. It's interesting that we actually have not found a specific mechanism that's been implied in weight gain. And sometimes we actually use medications to help people gain or lose weight. Glucose changes are obviously a concern in someone who is diabetic or pre-diabetic. Cognitive impairment is disturbance in our capacity to think. Benzodiazepines, for example, have been implicated in cognitive impairment over the long run. Cardiovascular disturbances usually concern the prolongation of the QT interval on EKGs. The QT interval is the space between the Q wave and the T wave, which represents ventricular depolarization. If that interval gets lengthened, then you are at a higher risk for abnormal rhythm disturbances, some of which can be deadly. Rashes can be benign to life-threatening, as is the case with Lamictal. Finally, there can be idiosyncratic responses that represent a genetic sensitivity to a drug. So all this means is that as prescribers, we have to pay very close attention to what our patients are telling us, even if they complain about something that we've never heard of or is not known as a common side effect for a specific medication. Just because everyone is different and everyone has a different genetic makeup, what they're talking about could actually be caused by the medication. So therapeutic index talks about how toxic versus safe a drug is. And practically what that means is that when the therapeutic index is high, there's a relatively wide range of dosages that can work between being effective versus being toxic. When the range is narrow, when the therapeutic index is very low, that means there's only a very limited number of dosages that we can give to a patient before we worry about the levels becoming toxic. So lithium is a good example of a medication with a very narrow therapeutic index, which is why we need to do blood work for it. Overdose can always be a concern because medications can be used to commit suicide. The newer medications tend to have a wider margin of safety. Sometimes we prescribe older medications in smaller quantities so that patients can't hoard them if they're planning to commit suicide later on, or sometimes we do pill counts. Drugs can interact with each other, of course, and prescribers usually use computer programs such as Hippocrates, which I like, to double check potential interactions. Certain drugs can increase or decrease the concentrations of others. They can influence metabolism or absorption. We also pay attention to which drugs are metabolized by the liver or the kidneys in case a patient has a medical condition that affects one of those. There are a lot of patient-related factors that influence a response to medication, such as a patient's attitude, which can obviously affect compliance. Misdiagnosis can delay treatment and may even produce worsening symptoms. A common example of that is giving a patient who is bipolar antidepressants, which can cause suicidal ideation or throw them into a manic episode. Coexisting medical conditions can and many times mimic psychiatric diagnoses, such as sleep apnea, which can often look like depression. And finally, recreational drugs and alcohol or even excessive caffeine use can also hinder the effects of psychotropic drugs. So for these reasons, patient education is very important. Generally, I like my patients to know what they're taking, why they're taking it, and things to look out for. Now, the optimal dose of a medication is often discovered by trial and error through clinical trials. Certain drugs have higher potencies than others, so it doesn't really make sense to compare milligram to milligram. A lot of my patients will say, hey, 300 milligrams of Wellbutrin is really high, and I just have to remind them that, when you're talking about Tylenol, 500 to 1,000 is considered standard. Now, in psychiatry, most dosing regimens are once a day, and so I like to tell patients that certain medications are like blood pressure medications, they're your maintenance medications. You want to take them consistently every day, get a steady state in your body, and the effects happen over the course of weeks to months. Whereas on the other hand, other medications are more like Tylenol, ibuprofen. You take them, you get the effect, and then they wear off after several hours. When patients ask how long they need to be on certain medications, the answer is going to, of course, vary based on their diagnosis, their response, and their own history. So depression, for example, is known to have high rates of relapse. When we reflect on where we are as a society, we have to remember that most psychotropic drugs were invented in the second half of the 20th century. We still do not have cures to many of the diagnoses that we try to treat. And as a result, many of the medications that we give don't actually eliminate the condition in the same way that, say, an antibiotic would eliminate a bacterial infection. What they do is they control symptoms. And even when patients are on effective medications, relapse does occur. So oftentimes when we give medications, we break the time frames down into the initial therapeutic trial, the continuation phase, and then the maintenance phase. Laboratory testing is also going to be necessary with certain drugs. As I mentioned, you want to keep an eye on the levels of lithium. You also want to keep an eye on how lithium is affecting kidneys and thyroid. With the antipsychotics, for example, we like to keep an eye on glucose and cholesterol levels. Other times it's also good to do laboratory testing before you start medications so that you have baseline values and you can rule out certain medical conditions. Some medications such as Celexa and Lexapro can also cause EKG changes, so you might want to do that on a yearly basis as well. As far as treatment outcome goes, the goal is always remission of symptoms. Most patients will simply be responders, which we define as a greater than 50% improvement from baseline. And in order to measure that, we often use subjective reporting from the patient. We also use rating scales. We can trend patients' values, and we can also compare one patient to another. So scales that I like to use are the PHQ-9, which asks depression questions, or the GAD-7, which asks anxiety questions. That being said, treatment failure is still relatively common, and it can be caused by a wrong diagnosis, intolerance of side effects, interactions with other drugs, or patient noncompliance. And even without those factors, some people just have treatment-resistant conditions that don't respond to medications. Treatment-resistant depression, for example, is very common, and once we've tried many medications, then we try to think of other alternatives. Electroconvulsive therapy has historically been effective, although patients generally don't like doing that because it causes a lot of short-term memory loss and amnesia. So alternatives can be transcranial magnetic stimulation, which sends a magnetic pulse into the brain, much less invasive. Ketamine is now often used in certain forms, nasal spray. It's been FDA approved for treatment-resistant depression, and patients will actually dissociate after they do that. The newest treatment that we're currently looking into is psilocybin, which is the active ingredient in mushrooms. And I work in clinical trials, and I'm actually working on one trial right now, in which we're giving psilocybin treatment to patients with treatment-resistant depression, and we're measuring their response to it. So tolerance is defined as decreased sensitivity to the intended or side effects of a specific medication. We think it's related to changes in the central nervous system that have to do with receptor configuration or density. We often see tolerance in psychiatry in the stimulants, the medications for ADHD, and as well as the benzodiazepines. Tolerance is one of the main reasons why patients often take more medication than they're prescribed. The opposite of tolerance is sensitization, in which patients become more sensitive to medications over time. Withdrawal, of course, is defined as physiological dependence to a drug, but it can be seen as a side effect. So to avoid withdrawal when we're taking patients off of certain medications, we always want to take them off as slowly as possible. Typically, agents with shorter half-lives are more prone to withdrawal. The half-life is basically the amount of time that it takes for the quantity of the med in your body to be reduced by half. So let's say you've got a certain amount of a medication in your body, let's call it 100. If the half-life of the medication is 5 hours, it'll take 5 hours to go from 100 to 50, and another 5 hours it'll go to 25, and another 5 hours it'll go to 12.5. Generally, we say that it takes about 5 half-lives for a medication to be out of your system. So if you think about that, if you have a medication that has a half-life of 24 hours, which is a day, it's going to take about 5 days for you to get that medication out of your system. Prozac, for example, has a very long half-life. It generally takes about 4 to 6 weeks for it to get out. On the other hand, Paxil, the other antidepressant, has a very short half-life, and so if you take people off of Paxil too quickly, they'll often get withdrawal symptoms, and that'll basically feel almost like a hangover. When we use a combination of drugs, that's known as polypharmacy. This is something that we generally try to avoid, but it has become common practice. The number of medications used simultaneously has increased over the last several decades. Currently, it's about 3 on average. There are recognized combinations of drugs such as California rocket fuel, which is venlafaxine combined with mirtazapine. Sometimes we use 2 medications in different classes to treat the same thing, such as using an SSRI and an SNRI, both to treat depression because they have different mechanisms of actions. This is known as combination therapy. Alternatively, we can augment one medication with another from a different class, such as adding an antipsychotic to an antidepressant. And there's FDA approval for those usages as well. Almost all patients with bipolar disorder, for example, have to be on more than one medication. And sometimes we give medications to counteract the side effects of other medications, such as giving Cogentin when a patient is on an antipsychotic. Of course, best clinical practice is to reduce the dose of the medication to keep side effects at bay, but sometimes, of course, that's not possible. And finally, it should be said that using a combination of medication plus therapy is almost always better treatment than either therapy or medication alone. This, of course, depends on diagnosis and severity. Now, in medicine, special populations require special consideration because there are increased risks when giving them medication. So children, we always say, should generally not be thought of as small adults. They have higher rates of metabolism, and as a result, drugs are often given to them on a milligram per kilogram basis. Unfortunately, for many years, manufacturers avoided conducting clinical trials on children because there's higher liability and there was a smaller market share for those drugs. So a lot of what we know for medications and how they affect children is basically from extrapolation from studies on adults. This is changing, of course. In 1997, the FDA passed the Modernization Act, which gave incentives to conduct clinical trials on children. Currently, I'm in a couple clinical trials, and we are testing migraine medications on adolescents and children. For ethical reasons, pregnant and lactating women are automatically excused from clinical trials. Only recently, we've allowed females of childbearing status to participate in clinical trials. And most of the studies that I've been on, we actually require them to have 2 forms of birth control. Even men are required to use one form of birth control. As a result, most of what we know about medication effects on pregnant and nursing women comes from case reports and retrospective studies. And the science on that is changing very rapidly. Back in the day, the thinking was if a woman became pregnant, we would take her off all her psychotropic medications. Nowadays, there are a lot of medications that we would keep them on, such as the antidepressants, because we feel that oftentimes the benefits outweigh the risks. So medications that I mentioned, such as Paxil, lithium, carbamazepine, Depakote, they all have connections to certain birth defects, and they're used with caution nowadays. Elderly patients who are over 65 are more susceptible to side effects, and they also excrete drugs more slowly from their system. So we generally start in lower dosages, about half the normal starting dose. Interestingly, elderly people are also on a higher number of medications on average, about 3 to 5 in the community and about 10 when hospitalized. So we're very concerned about sedation and falls. We think about decreased renal clearance and hepatic metabolism. Cognitive impairment from medications can also mimic dementia. Other concerns that we have include hypotension, cardiac conduction abnormalities, anticholinergic effects, respiratory depression, and of course Parkinson's disease. Patients who are medically ill also present specific challenges. For example, if a patient has diabetes, you want to avoid giving medications that will increase weight gain or glucose. Patients with COPD should generally not be given strong sedating drugs because of the risk of respiratory depression. There are also many drug interactions with non-psychiatric drugs that have to be checked. So for example, if I'm seeing a patient and they're taking lithium, but we check their labs and suddenly their kidney clearance has decreased a little bit, I will probably send them to nephrology if they don't already have one. And then I will regularly consult with nephrologists about how should we adjust their lithium dose, should we take them off. I will also consult with cardiologists if one of my patients is taking Adderall or one of the stimulants, because it's known to increase hypertension and it's also contraindicated in certain cardiac abnormalities. Finally, substance abuse can also present a problem in terms of treatment. One of my previous supervising physicians used to joke, he said that when patients are on street drugs, it's like they're putting their hand on a weather vane and getting zapped by lightning. And here we are in the clinic trying to give them like a AA battery to help their depression. Basically what that means is that the effects of street drugs often outweigh medications that we prescribe. Not always, of course. There are certain times where it's appropriate. You can treat someone who maybe have a mild form of substance abuse, but other times it may be wiser to send them someplace, maybe to the hospital or a place where they can detox first before you try to treat some of their underlying psychiatric illnesses. Now, the FDA, of course, has the authority to approve a drug for clinical use. As prescribers, we're not limited to only FDA-approved medications. Off-label usage is not against the law, and it's not considered a departure from good clinical practice. That being said, we are responsible for what we prescribe, and oftentimes malpractice suits are determined by making reference to what is standard practice for a given medical condition. Placebos are interesting. They're pharmacologically inactive substances, and they're popularly called sugar pills, although these days they're not actually made of sugar. And in clinical trials, placebo-controlled trials are considered the gold standard, where you have one group who are getting the study medication and another group who are getting the placebos, and the investigator doesn't know who's who. But when we're talking about outpatient practice, it's generally considered unethical to give people placebos unless you inform them first, and as a result, it tends to be very rare. The placebo response rate is actually pretty high. It can be 30%, depending on the condition, in anxiety and depression, but much lower in bipolar and schizophrenia. And to me, that kind of points to the larger effect that genes and physiology probably have in bipolar and schizophrenia, as opposed to anxiety and depression, which tend to be more influenced by patient circumstances, attitude, and therapy, and things like that. But that's just my opinion. And finally, I want to talk very briefly about medication-induced movement disorders, and these are usually caused by drugs that block dopamine type 2 receptors. In other words, these are the antipsychotics. Parkinsonism can look very much like Parkinson's disease. There can be muscle stiffness, cogwheel rigidity, shuffling gait, drooling. The pill rolling tremor, where they're going like this, is relatively rare. All the antipsychotics can cause this, and typical treatment includes the anticholinergics, benztropine, or diphenhydramine. Neuroleptic malignant syndrome is a life-threatening complication that can occur at any point in treatment. It is very rare, about 0.01 to 0.02%, and the symptoms are muscular rigidity, dystonia, hyperthermia, sweating, increased pulse and blood pressure. Dantrolene and bromocriptine are the standard treatments. Dystonia are prolonged muscle contractions that result in abnormal movements or postures. So it could be protruding of the tongue, oculogyric crisis, where your eyes are fixed in a certain direction, dystonic postures of the neck, limbs, and trunks. And various treatments exist, such as the anticholinergics, Benadryl, and some of the benzodiazepines. Akathisia is something I've learned that you have to actually sit down and explain to patients. They will subjectively describe it as feelings of restlessness, a sense of anxiety, jitteriness. Basically, they'll feel the need to move around, and a lot of times they won't realize that it could be a side effect of the medication. For some reason, middle-aged women are at higher risk, and to treat it, we can use beta blockers, benzodiazepines, anticholinergics, cyproheptadine. Tardive dyskinesia, in my opinion, is one of the more scary movement disorders. It's a delayed effect of the antipsychotics. It usually occurs at least after 6 months of taking it, sometimes after many years. There are many abnormal, involuntary, irregular movements, such as jaw shifting, tongue protruding, repetitive motions of the limbs and trunk, and it can be very disturbing to a patient's lifestyle. It occurs in about 10 to 20% of patients who are treated for more than a year with the antipsychotics. About 5 to 40% of cases will remit, and 50 to 90% of mild cases will remit. There are 2 medications that can treat tardive dyskinesia. And other movement disorders include postural tremor. Tremor, they define as a rhythmic movement that occurs faster than 1 beat per second. So medications like lithium, stimulants, antidepressants, caffeine can all produce tremors. Classically, people probably know the intention tremor. It's the tremor that occurs when you're trying to reach for something. We can often treat that with propranolol. Restless leg syndrome is another common side effect. It's the sensation in your legs that something's creeping in your muscles and you have to move. This can be very disturbing when people are trying to fall asleep, and so it can be rare side effect from the SSRIs. Oftentimes we can do leg massages, ropinirole, or pramipexole.